Whether providing access to life-saving drugs to 5 million people living with HIV/AIDS, or uniting global leaders to create innovative solutions to our most commanding challenges, the Clinton Foundation is already making its impact felt in the lives of over 400 million people in 180 nations around the globe. We look forward to collaborating with the Clinton Foundation through the Clinton Health Matters initiative to save lives that would otherwise be ruined and lost to prescription drug abuse. 1 year ago today, President Clinton pledged to staunch the epidemic of prescription drug abuse in our nation. With this commitment, President Clinton and his colleagues are once again proving that our best intentions can become our best practices with the power to transform countless lives. Please join me in welcoming the 42nd President of the United States, founder of the Clinton Foundation, and visionary public health advocate, William Jefferson Clinton.
Everybody here knows that prescription drug abuse and misuse is now our fastest growing drug problem, although sadly, heroin abuse is catching up rather rapidly. I got involved in this, I'm ashamed to say, from a perspective of total ignorance. Until a couple of years ago, within a 10-day period, 2 young men, 30 and 32, whom I knew, died in their sleep after drinking 5 or 6 beers and popping an OxyContin. Both of them were given these pills by their lady friends who were totally ignorant of the biochemistry of what was going on. And I wondered how many other people were dying either from addiction or ignorance. And we began to do what we could. As you just heard, this is now a year since we have been working on this. There is too little focus given to however much money you have and whatever you propose to do. How do you propose to do it to turn your good intentions into real changes?
Although well-intended, these efforts have contributed to soaring opioid use, so much so that by 2010, enough prescription opioids were prescribed in the United States to supply every adult a 4-week continuous around-the-clock supply of Vicodin. Chronic pain is common, and it's historically been undertreated, and some have framed efforts to rein in runaway opioid prescribing as a threat to quality of care for patients in pain. Yet nothing could be further from the truth.
Why I am so interested in this issue is that, first of all, I was a prosecutor for 8 years, managed an office of 400 people, and a third of our cases were drug cases. And I saw firsthand that if you got in there and got someone treatment and got them off drugs, it made the world of difference, not only for them, but also for victims and other crimes.
We got a prescription for 20 OxyContin. So I had that, and I went home and I took one and said, "Well, I'm not taking that again." But I had 19 OxyContin sitting in my medicine chest. And being a good economist, I was thinking, I wonder what the street price of this would be. Now, of course, I wouldn't do that, but it's like, what we've done is make these drugs so available that now people have the opportunity to do things with these drugs that they otherwise shouldn't.
This is a complex, multifaceted problem which really requires a comprehensive, evidence-based strategy to address it, and that we have, as a nation, an urgent need to address it. Every day, lives are being taken, lives are being disrupted, and the toll is enormous. FDA is, of course, one player in this picture, but I think we have very important roles to play. I think that together we do, though, need to really make sure that we have a comprehensive approach that really looks at the issues of appropriate physician prescribing and use, that looks at issues of diversion, that looks at issues of appropriate disposal, that looks at issues of ensuring that we can, our physician community and our healthcare system, as well as the broader community, can recognize signs of addiction, and that we have an addiction system that people can rapidly and readily access, and that we can provide treatments that work.
Not only am I the sponsor of the Mental Health Parity and Addiction Equity Act, which requires insurance companies to pay for this treatment, I'm also a consumer who's been in and out of rehabs and ERs my whole life because our medical system does not reimburse for chronic care management for those who have addiction and mental illness. So one of the answers is we need to pay for access. We need to pay for those kind of preventive measures that will only come when we start treating addiction and mental illness like we do asthma, like we do cardiovascular disease, like we do diabetes. We wouldn't imagine telling someone with diabetes, come back until you need your legs amputated and you go blind. That's exactly how we treat addiction and mental illness in this country. We wait until it becomes a crisis, and then often insurance companies say you have to fail first before you get led into a treatment facility. And of course, no preventive health care is provided along the way. So I would propose a checkup from the neck up in our pediatrician's office, in our primary care physician's office, in our orthopedist's office, in our gynecologist and obstetrician's office, and our geriatrics office. If we're not asking about your mental health, you're not doing what you need to do to get to the real health issues that are, as you know, in a public health setting like this, the real cost drivers in healthcare today. 3 out of 4 are all behavioral, and yet we segregate the mental health and behavioral health care system from our physical health system. And until we combine the two and stop this age-old mentality of segregation in this case of our mental health versus overall health. And by the way, the IT is not linked, so there's no way for doctors to know that I've been in those rehab settings. We need to address these problems, and if we do, I think we'll catch a lot of these problems in the way that we would any other chronic illness. Well, as Dr. Huff said, I mean, the behavioral economics are that in my own life, I haven't had to go to the ER in 3 years since I've been in recovery. I was going to the ER all the time before that. I had back pain, I had irritable bowel, I got into accidents all the time, I needed stitches. My medical spend dropped precipitously once they treated the underlying issue and I got into real. So this isn't a matter of saving money by cutting or paying more money for doctors to do the screening early, because all the costs, the insurance companies are going to do the health economics, doctor. They're going to recognize that it pays to have someone in the office doing that screening, brief intervention, referral, and treatment.
And since we're sitting in a school of public health, I feel obliged to also say, let's put more emphasis on prevention. Let's try to stop these problems from happening in the first place.
We're near Washington. It would be appropriate now to talk politics. And one thing that we could do is get some of these recommendations, put them in an executive order, and ask the President of the United States to sign it, because this is an epidemic, as has been said over and over again, and we need a response yesterday.
As a result of our conversation here today, we're in a much better position to appreciate the regulatory and policy environments that shape people's exposure and access to drugs that can lead to abuse, addiction, and overdose. We've also been challenged to think about the need for prevention programs and treatment services and the ways in which healthcare systems can hinder or facilitate controlling this epidemic. Moving forward, how we frame the epidemic of prescription drug abuse, misuse, and overdose will be important. We have much work left to do, and today's meeting is just the beginning of an initiative that convenes key stakeholders so that we can better understand the problem and find solutions.